Welcome to episode 86, Hospitals and Provider Organizations, where we explore how the HITRUST R2 framework operates within healthcare delivery environments. Hospitals represent some of the most complex and high-stakes settings for cybersecurity and privacy assurance. The balance between clinical care and technical control is delicate. Systems must remain available for patient treatment even under duress. The R2 framework helps translate general assurance expectations into healthcare-specific terms, guiding providers in securing data, maintaining trust, and sustaining clinical continuity. Understanding the context of provider workflows allows controls to fit naturally into care operations rather than disrupting them. In this environment, every safeguard must protect patients as much as information. Beyond EHR platforms, hospitals depend on hundreds of specialized clinical systems and medical devices. These include bedside monitors, infusion pumps, imaging machines, and laboratory analyzers. Many still rely on legacy operating systems or vendor proprietary software that complicates patching and monitoring. R2 guidance recognizes that full modernization may not be immediately feasible, so compensating controls, such as network isolation and device inventory management, play a key role. For instance, segmenting unpatchable devices from core networks limits exposure while maintaining function. Documenting these safeguards shows that risk is managed consciously, not ignored. The intersection of biomedicine and cybersecurity illustrates how safety, privacy, and continuity converge in healthcare settings. Protected health information, or PHI, flows constantly through hospital systems. From registration to discharge, data passes between intake desks, labs, and insurers, often through automated interfaces. Mapping these flows clarifies where sensitive data is stored, transmitted, or transformed. For example, understanding that lab results travel from an analyzer to the EHR via an integration engine helps determine where encryption and logging controls apply. Identifying both internal and external data paths ensures that every link, whether local, cloud-based, or third-party, is covered by appropriate safeguards. R2 assessments emphasize documenting these flows to reveal potential exposure points and to demonstrate that data protection follows the patient journey from end to end. Identity management in hospitals is uniquely challenging because clinicians, staff, students, and contractors share systems but perform vastly different functions. Identity models must support role-based access, temporary privileges, and frequent changes in assignment. For instance, a nurse may move between departments or facilities within a day, requiring dynamic access without security gaps. Implementing centralized identity directories with multi-factor authentication balances speed with control. R2's focus on least privilege ensures each account aligns precisely to role and duration of need. Proper identity modeling transforms access control from a burden into an enabler of secure, efficient clinical collaboration. Shared workstations and mobile carts introduce additional access complexity. Many clinical areas rely on communal devices where multiple staff members log in throughout a shift. Without disciplined session management, this convenience can become a risk. Timeouts, badge tap-in systems, and single sign-on solutions help maintain both security and workflow continuity. For example, badge reauthentication lets a clinician move quickly between patient rooms without leaving records exposed. In R2 terms, these mechanisms demonstrate that access controls account for real-world context. Security in shared environments is not about rigid restriction. It is about precision and adaptability that respect clinical pace while preserving privacy. Network segmentation is critical in clinical zones where sensitive systems coexist with general networks. Segmentation isolates medical devices, administrative systems, and guest Wi-Fi to prevent lateral movement in case of compromise. Hospitals often implement dedicated VLANs and firewalls for high-risk equipment, such as imaging servers or medication dispensing units. For example, separating diagnostic networks from internet-connected kiosks minimizes exposure to ransomware spread. Maintaining diagrams, firewall rules, and monitoring logs provides the evidence assessors expect under R2. Segmentation is both a control and a design philosophy. It ensures that operational convenience never becomes a single point of failure. Availability requirements in healthcare far exceed typical enterprise standards. Even brief downtime can delay treatment or jeopardize safety. Hospitals maintain detailed downtime procedures, including manual charting, alternative communication channels, and data restoration priorities. For example, during an EHR outage, clinicians may revert to paper orders, later reconciled electronically. These procedures are tested through scheduled drills to confirm readiness. R2 connects these practices to continuity controls, ensuring that recovery objectives are defined, achievable, and periodically validated. Availability in this context is not optional. It is a moral obligation, safeguarded through redundancy, testing, and disciplined operational planning. Vendor relationships and business associates extend security responsibility beyond the hospital's walls. Every vendor handling PHI must sign a business associate agreement defining data protection expectations, breach notification timelines, and permitted uses. High-risk partners, such as billing processors or cloud hosting providers, require ongoing assurance through audits or certifications. For instance, verifying that a vendor maintains encryption and incident response capabilities equivalent to the hospital's own ensures consistent protection. R2 encourages tiered oversight so that each relationship receives proportional attention. Managing business associates responsibly transforms compliance from contract language into verifiable stewardship. Audit trails are the invisible guardians of clinical operations. They record who accessed what, when, and why, vital for both security investigations and patient trust. Comprehensive logging across EHR, network, and device systems enables forensic review when incidents occur. For example, logs may show whether a staff member viewed a patient's record without clinical justification. Maintaining audit integrity requires synchronization of system clocks, restricted log access, and documented review procedures. Under R2, audit trails double as evidence for multiple controls, demonstrating accountability at every level of care. When managed well, they create a transparent chain linking technology, policy, and ethical responsibility. Privacy considerations take on special meaning in patient care settings. Beyond regulatory requirements, clinicians must balance confidentiality with the need for information sharing in emergencies. Curtains and quiet conversations matter as much as encryption. Hospitals train staff to follow minimum necessary principles, disclosing only what is required for treatment. For instance, a nurse discussing test results should do so discreetly, even within secure systems. R2 recognizes that privacy extends beyond technology. It is cultural, behavioral, and situational. Documenting training attendance, policies, and real-world reinforcement demonstrates that privacy is lived, not merely stated. Incident response in clinical settings requires precision under pressure. A cyber event can disrupt life-critical systems, so hospitals design specialized playbooks that prioritize patient safety. If ransomware locks an EHR, response teams coordinate with clinical leaders to maintain manual workflows while restoring systems. Communication protocols specify how to alert staff without causing panic or downtime. Evidence from tabletop exercises and response timelines proves readiness. Under R2, incident response is more than containment. It is continuity management in a healthcare context, ensuring treatment never stops, even when technology fails. Evidence sources for provider organizations reflect their unique blend of operational and regulatory controls. Common items include EHR audit logs, business associate agreements, downtime drill records, device inventories, and risk assessments. Additional evidence may involve medical device patch schedules, access badge reports, and privacy training logs. Each artifact ties back to R2 requirements demonstrating policy, process, and proof. Collecting and organizing this evidence not only supports certification, but also improves daily governance by revealing gaps before they affect patients. Evidence management in healthcare shows that compliance documentation and quality assurance share the same DNA: accuracy and accountability. Ultimately, R2 within hospitals and provider organizations centers on risk-based, patient-centered controls. Security, privacy, and resilience exist to protect care delivery, not to complicate it. Each safeguard, whether a password policy, network isolation rule, or audit review, is a component of patient safety. When implemented thoughtfully, R2 becomes invisible to clinicians, yet invaluable to trust. It enables innovation, interoperability, and compliance to coexist without friction. The most mature providers treat assurance as part of care quality itself, proving that protecting data and protecting lives are inseparable goals in the modern healthcare environment.